Our next section is on vitreoretina surgery, part 2. I'm Sandra Rocio Montezuma from the University of Minnesota. Thanks to the organizers of this meeting, to Dr. Bakri, Dr. Blody, for this amazing retina program. Our first speaker is Dr. Yasha Modi, who's going to talk about surgical treatment of epiretinal membranes.
Well, thank you so much. These are my financial disclosures. And if I think back to my time in fellowship, I remember that a lot of the decision-making in epiretinal membrane was thresholded by a visual acuity cutoff. And when we talked about counseling, it was oftentimes the rule of thirds. That is, about a third will get better, a third will stay the same, and a third will improve. But I think many people in this audience will challenge that paradigm because OCT imaging and improvement in surgical technology have challenged this. So certainly epiretinal membrane surgery is really fun, but I think the hardest part of surgery for me is at least when to operate and when to observe. And can we predict outcomes better than the rule of thirds? So let's take this 64-year-old woman. Vision is 20/25 minus. She's noted metamorphopsia. And we see some critical findings on the OCT, which we'll get to. But I'd want to know, is she symptomatic and have her symptoms worsened and over what window of time? Is this patient likely to progress? And what are the positive and negative prognostic factors for surgery? Well, when we think about risk factors for progression, this comes from our natural history studies. About 17 to 39% of eyes will progress, but unfortunately, the predictors are not that helpful. Vitreous adhesion with epiretinal membrane and ERM in the contralateral eye. And unfortunately, there are no OCT-based features for predicting progression, and this is potentially a major problem. Now, my clinical intuition says that eyes that progress seem more likely to progress, but this is oftentimes hard to study because we're likely to operate on those patients prematurely. So then how do you know what is a reasonable stage to operate on somebody? And I think this is a judgment, but ERM staging may be helpful for understanding anatomy and visual acuity correlations. And the one that I particularly like is the OCT staging by Andrea Govetto and colleagues. And what this is essentially a 4-step stage where stage 1 is preservation of the foveal contour. These are asymptomatic epiretinal membranes, but eventually this progresses and we have anterior-posterior traction that results in outer nuclear layer elongation, loss of the foveal contour, and centripetal migration of the inner retina. And this eventually progresses to the point of developing what's called ectopic interfoveal layers, where we have progressive centripetal migration and maybe even more anterior-posterior traction. Finally, by stage 4, we have persistent Eiffel, but now we're getting disruption of those retinal layers. The one thing that I want you to take home today is that the visual acuity decline is nonlinear in this stage. So oftentimes, by the time you get to stage 3, the vision may be reasonably good. But when we operate on those patients with Eiffel, these patients have a poor prognosis for both anatomic and visual acuity recovery. So visual acuity may be a poor indicator on when to decide to intervene. So what to consider then when deciding not to operate? Well, we can use presence or metamorphopsia. Vision poorly correlates with metamorphopsia and anisoconia. The severity of metamorphopsia significantly degrades visual functioning. So changes in symptoms, I think, is certainly a reasonable thing to use, even though this is poorly studied, but it may be reasonable to start the discussion at that time. So let's go and say the patient decides to have surgery. How do you counsel this patient? Well, I think it's worthwhile to understand positive and negative prognostic factors. Younger age, short duration of symptoms, and better vision are all positive prognostic factors. But look critically at the OCT. Thin GCIPL, absence of Eiffel, longer photoreceptor outer segment distance, as well as EZ and ELM preservation are all positive prognostic factors. Now, in the converse, negative prognostic factors include disruption of the inner and outer retina that can represent Eiffel or EZ loss or shadowing. And we learned actually from Colin McCannel, who'll speak shortly, that baseline visual acuity is a really strong predictive factor. And that is, if you start with better vision, you're more likely to maintain 20/25 or better vision. The caveat, however, is that macropsia and micropsia are less likely to improve. So take these two patients. They both want to have surgery. Maybe if I'm counseling them, I would say the first patient's more likely to maintain excellent vision. Macropsia is likely to persist, but the goal of surgery is really stabilization of symptoms. Now, the second patient, vision is 20/80. Their vision is likely to improve with surgery, but they may be rate limited by poor long-standing vision. When we think about controversies in epiretinal membrane, would I operate on a patient with excellent visual acuity, maybe somebody with 20/20 minus vision? And I think we're going to get sort of level 1 evidence through the DRCR through protocol AM. But right now, what I would sort of say is that if they have metamorphopsia, if they're demonstrating worsening vision over time, this may be a patient worth operating on. Now, would I peel ILM on all of my cases? Of course, we all know this conversation, the pros, lower recurrence of epiretinal membranes, but the cons is that we may be inducing iatrogenic injury even in the setting of what we would otherwise consider a traumatic peeling in the form of dissociated optic nerve fiber layer or swelling of the arcuate nerve fiber layer. And while they may not have impact on vision, there's some mixed studies showing perhaps that it affects microperimetry. But the reality is sometimes we cannot choose. So take this patient, 2100 vision, and what we can see on the left image is that I'm peeling the epiretinal membrane, then staining, and what you're seeing is a fractured ILM, meaning that even in just trying to peel the epiretinal membrane, we frequently will end up removing the ILM as well. So in excellent visual acuity eyes, I restain, and if the ILM is not fractured, in my practice, I oftentimes may leave it alone. So some conclusions. Follow symptomatic epiretinal membranes closer. Consider observation if they remain stable, and obviously surgery if they worsen. Do not use visual acuity as your only metric to intervene. And remember the nonlinear loss of visual acuity when you're considering your OCT. And it's reasonable to operate on eyes with excellent vision if they demonstrate symptomatic worsening. And I think we're going to get much more clarity on this topic over time with level 1 evidence. And I think ILM peeling is very much discretionary at this time. Thank you.
Thank you. Our next speaker is Dr. Christina Weng, who's going to talk about macular buckling for myopia-associated pathology.
Thanks very much to the meeting organizers for the invitation back this year to Sub-Day. Here are my disclosures. I'm going to start off with a photograph here. This is my adorable little niece, Stella. And Stella failed her school vision screening test last year at the age of 6 and was found to have mild myopia. Now, sadly, Stella is not an outlier here, and so I thought I would kick off the talk with this slide, because I don't think we can really talk about myopia-associated retinopathy without first talking about myopia, which has now reached global epidemic proportions. In fact, over the past 26 years, the prevalence of myopia has grown to reach nearly 45% in the United States, and it actually exceeds 90% in some Asian countries. And there's been consistent and repeated estimates that by the year 2050, myopia is going to affect nearly half of the world's population, and 1 out of every 10 people are going to have high myopia. It's a fascinating disease because we don't fully understand the root cause, but we understand that it's likely driven, at least in part, by a combination of genetics, behaviors, and environment. So for example, if you have 2 myopic parents, your risk of having myopia is 5 to 6-fold greater than someone whose parents are emmetropic. And that's despite genome-wide association studies that only account for a small fraction of phenotypic variation. We also know that things like near work and increased time indoors also drive myopia development and progression. And just like with any other disease, the best treatment for myopia is primary prevention. And so there's a lot of different strategies that are actively being explored, as you can see here: spending more time outdoors, limiting near work. Low-dose atropine has also been looked at in detail in many studies, although still debated because of effects like the rebound effect noticed in many major trials, including the LAMP study. And orthokeratology is even more controversial because of its association with infection and its limited study primarily to Asian populations. So the bottom line is that no consensus exists. There are no universal guidelines at this point. But fortunately, the good news is that there are several ongoing trials and initiatives, including from the Academy, that will hopefully provide more definitive guidance in the future. And the reason I mention prevention is because, as we know in this room, myopia is associated with multiple ocular comorbidities, including retinal tear and detachment, myopic macular degeneration, myopic macular hole, and myopic traction maculopathy, or MTM. And the risk of developing these conditions increases the greater the degree of myopia. So for each 1 diopter increase in myopia, the risk of myopic maculopathy increases by 67%. And this has serious downstream effects, not only vision loss, which leads to decreased quality of life, and multiple studies that have shown it's linked to increased morbidity and mortality, but also has some significant economic implications. So global potential productivity loss is estimated to be about $6 billion from myopic maculopathy and nearly $1 trillion from uncorrected myopia. On top of that, myopic maculopathies are really challenging to treat using our conventional approaches. And so some have proposed using macular buccal devices for some of these conditions. Take a look at the figure to the right. That's from a paper that was just published recently, where the authors felt like macular buckle should be considered for certain stages of the MTM staging system. Certainly controversial, no consensus that's been arrived, and mixed data, of course, but there have been many studies that have shown that macular buckling may increase surgical success, and that's by alleviating the anterior-posterior tractional forces. That can be done with or without a concurrent vitrectomy, which of course we know alleviates the tangential forces. Several macular buckles do exist and have been developed. You can see some of them listed there, and all of them have their own unique characteristics, but the common thread that they share is that they all alleviate the anterior-posterior tractional forces by supporting and imbricating the macula. The problem is that macular buckles are not commercially available in the United States or in many other countries around the world, and so sometimes we're forced to get creative. I just got back from Taipei, Taiwan a few weeks ago, and had the chance to meet Pei-Chung Wu, who actually has reported and published a self-constructed macular buckle using Gore-Tex vascular grafting material, which I think is pretty cool. Additionally, some of you may have caught my talk at this summer's ASRS, another self-constructed buckle using 4 common buckling elements, and it's a modification of a recently published technique by my friend Aaron Nagel, whose citation I've left below. But essentially what you're doing is you're suturing a 287 tire to a 240 band, and that becomes the macular buckle or sling. And you're going to pass that through the inferior rectus, the inferior oblique, the lateral rectus, and the superior rectus. Adjust that macular buckle so that the 287 is supporting right underneath the macula. And then you're going to imbricate by suturing the ends of the 240 to the encircling 41 band that was previously placed. So you can see I'm sort of estimating the position and then suturing it in place superiorly in surgeon's view, and then refining the position and anchoring it inferiorly with the 240 band sutured to the encircling 41 band. This is a patient with a myopic macular hole-associated full total retinal detachment who ended up doing really well. She actually improved to 20/60. I actually saw her just a couple of weeks ago from an original visual acuity of counting fingers. And that's her final configuration. We don't work in that space very often as retinal surgeons, right? So it's important that if you do attempt macular buckling to be very mindful of posterior structures like the vortex veins and the optic nerve. But fortunately, there actually haven't been that many complications reported in the literature, and they seem to be well tolerated overall. And Barbara Parolini from Italy actually recently published her series of 116 eyes looking at atrophy in association with macular buckles and didn't find a difference between that group and compared to the controls. So in summary, the prevalence of myopia is rapidly rising and expected to affect half of the global population by 2050. And myopia is associated with a number of serious retinal issues like myopic macular hole, MTM, and myopic degeneration that are unfortunately oftentimes refractory to our conventional techniques. So the next time that you have a patient in your chair with one of these conditions, you may consider the use or addition of a macular buckle. And if none are commercially available in your area, there's now been several self-constructed buckles that have been described and published in the literature. I've left my contact information if anyone has any questions. Thanks so much.
Thank you. Our next speaker is Dr. Mathew MacCumber, who's going to talk about risks of proliferative vitreoretinopathy based on a large data set.
I want to thank the organizing committee for allowing me to present this for myself and my coworkers. Disclosures. So proliferative vitreoretinopathy, or PVR, is a major complication of regmatogenous retinal detachment repair. It's the most common cause of failure and has been reported generally at about 5 to 10% of cases. PVR is managed, as we know, with vitrectomy, membrane peeling, scleral buckle, gas or silicone tamponade. However, there have been medical interventions that have been investigated, such as methotrexate, anti-neoplastic drugs, steroids, biologics, some supplements. It'd be nice to know which patients are at the most risk of PVR so we can use these most appropriately. So in this study, we used the Vestrum Health database and look for patients that underwent unilateral rhegmatogenous retinal detachment repair between January 2015 and February 2023. They had to have a surgical procedure within 1 month and at least 1 month of follow-up. We didn't want patients that had retinal detachment from PDR, so we exclude those, and they couldn't have history of PVR. To refine our data set, we used some text fields as well, certain things like retinal star fold, retinal traction, to again optimize our patient population that had PVR. And then we also looked at patients that had RD in one eye and subsequently RD in the second to see if PVR predicted a higher rate of PVR in the second eye. So overall, we had 57,264 patients, and the PVR rate was 11% in this population. If we look at rate of PVR in different age categories, younger ages, as expected, have a higher rates of PVR. However, there was a little bit higher rate in older patients as well, perhaps because of a slower presentation in our clinics. When we look at rate of PVR in different baseline visual acuity categories, as we could expect, worse visual outcome predicted higher rates of PVR. Worse vision could be because of chronicity, macula off status, and such. So this is the univariate logistic regression model and the multivariate logistic regression model, but let me just summarize the multivariate results, which indicated factors statistically significantly associated independently for increased odds of PVR development. If we look at systemic factors, younger age, as I had said, is a predictor. History of smoking also came out. In fact, there was a dose response. Active smokers had the highest risk, former smokers less, and never smokers the least rate. That has been seen before in some other smaller studies. Hypertension was a risk factor. I don't think that's previously been reported. Another thing is females had a higher rate. Now, I would think of PVR in males, but I think that's because trauma is almost entirely in male population, and that, of course, is a risk factor. So it's not surprising, actually, to think about it, though, because females have a higher rate of inflammatory disease. So I can see that they did come out that they have a slightly higher rate of PVR. When we look at ocular factors, poor baseline visual acuity, as I mentioned, pseudophakia, aphakia, vitreous hemorrhage, history of ocular trauma, giant retinal tear, and things that cause inflammation or associated with inflammation, choroidal detachment, history of uveitis, and ophthalmitis. Now let's go on and look at patients that had bilateral retinal detachment. If we look at first patients who had primary RD without PVR, 9% of those had an RD in the second eye within the study period, and of those, 3% developed PVR. If we look at patients that had PVR in the first eye, 6% of those went on to retinal detachment in the opposite eye, and 10% of those had PVR. So indeed, a history of PVR is a risk factor for the second eye. In fact, it's 3.5 times. If we look at visual outcomes in patients who had these bilateral retinal detachments, we get some interesting findings. If the first eye had RD with no PVR, there was visual improvement after surgical procedure, as would be expected. Nice to see. If there's a second RD in the opposite eye, or an RD in the opposite eye, no PVR, also improvement in vision. However, if that second eye had PVR, there was a worse outcome. Again, not that surprising. PVR predicts poorer outcome. But if the first patient had PVR in the first eye, there was a little bit less vision. If the second eye didn't have PVR, there was better vision. But if the second eye had an RD and then got PVR, there actually was better vision. So what this suggests is that either patients are presenting sooner, they're more worried about their outcome because they had RD with PVR in the first eye, or perhaps surgeons are already taking measures to decrease the rate of PVR. For instance, adding scleral buckle, laser 360, or maybe a pharmacologic agent. So the limitations of this study, it's a large retrospective data set, limited access to operative notes. The second eye PVR risk may be confounded by surgical techniques. We didn't have operative records, so doctors could have had, as I had mentioned, scleral buckle or 360 laser, for instance. And in conclusion, the odds ratio was about 3.5 times So a substantially higher risk of PVR in the second eye if the first eye had history of PVR. And this is likely due to systemic factors such as age, history of smoking, hypertension, female, as well as some genetic factors. Potential impacts on surgical decision-making, steps during the second eye surgery. If there is history of PVR, then consider prophylactic treatment, such as pharmacologically, or consider scleral buckle, 360 laser, other surgical approaches that might improve outcome, because you have to expect that there's a higher risk of PVR. And finally, as a caveat, the final vision in the second eye in patients who had history of PVR was better than in the final vision in the second eye if there was no history of PVR. And again, this suggests that surgeons may already be taking measures to decrease the risk of PVR and poor outcome in that second eye. Thank you.
Our next speaker is Dr. Colin McCannel, who's going to talk about macular hole surgery.
I'd like to thank the organizing committee for inviting me to present this talk, Macular Hole Surgery, My Disclosures. Macular holes are perhaps the most common rare condition that we take care of as retina surgeons, with an incidence of 8.7 per 100,000 patients per year. The two main goals of macular hole surgery are really to achieve the best visual acuity for our patients, which is accomplished by closing the macular hole with a surgical intervention. How do we close macular holes? Well, prior to 1991, there was no treatment for macular holes. Kelly and Wendell noted that a gas bubble placement after vitrectomy with face-down positioning could close macular holes, and they accomplished a 58% success rate in closing macular holes in 1991, which was nothing short of a revolution at the time. Here are the major milestones in macular hole surgery, each of which we'll briefly discuss. In 1997, Klaus Eckert brought to us the concept of internal limiting membrane peeling. Internal limiting membrane peeling, or ILM peeling, increases the closure rate from what was in the 80 percentiles up to 95% plus following the introduction of internal limiting membrane peeling. There are many studies that also show that it improves visual acuity outcomes in the patients that had macular hole closure with internal limiting membrane peeling. Furthermore, internal ILM peeling reduces reopening rate by a factor of approximately 7, as shown by Rahimi and colleagues. Here's an example of a typical ILM peeling procedure for macular holes with an ILM rhexis in a patient that had preoperative visual acuity of 20/80 with a relatively small macular hole and a postoperative visual acuity of 20/20. There were still holes that didn't close despite ILM peeling, and in 2010, Jerzy Naraki introduced the concept of inverted ILM flap. This concept led to an avalanche of ILM procedures that are all used today. Here's an example of a patient undergoing a ILM flap procedure, in this case a floret procedure, one might call it, and the preoperative visual acuity was 2800 and the postoperative visual acuity 2060. There were still holes that didn't close despite ILM flaps and other ILM procedures. So in 2015, Tamer Mahmoud introduced the idea of autologous retinal transplant to close the most difficult to close macular holes, such as in high myopia, after previous macular hole repair attempts that were failures. And this improves macular hole visual acuity outcomes and closes the refractory hole and also prevents retinal detachment in these high myopic eyes. Here's an example of a patient that had multiple surgeries, including PVR and for macular hole closure, and has a free flap from the periphery of retina placed in the macular hole by McCannel, and here it's shown under the PFL bubble it's positioned, air fluid exchange is done, and a gas bubble placed, and the final visual acuity that held for 6 years was 2100. Not everybody was excited about doing free flaps from the periphery of retina, so another idea that came up in 2019, introduced to us by Stanisław Rizzo, was using amniotic membrane grafts. He demonstrated that a subretinal amniotic membrane graft in the macular hole would lead to closure and improved visual acuity, and Moham and colleagues demonstrated that epiretinal membrane grafts could accomplish similar outcomes. Here's an example by one of our fellows, Blake Forrest, and my colleague Irina Sway, showing a membrane graft placed into the macular hole in a patient that had a refractory macular hole that was 1.3 millimeters in size and ended up with a visual acuity outcome of 20/70. Here's a patient, very complex, with a history of VKH, high myopia, a massively large peripapillary choroidal neovascular membrane that's tenting up the nasal retina, and the macular hole could not close, and she developed a retinal detachment from the macular hole, and an epiretinal amniotic membrane graft was placed, and the macular hole was closed, and she perceived a subjective improvement in visual acuity. So those are the techniques. What about the predictors of success for macular hole surgery? Getting the best outcomes is most important. Most studies show that the preoperative visual acuity, size of macular hole, and duration of macular hole, and the age of the patient are the most reliable predictors of postoperative visual acuity outcome. Since we can't affect the size, the age of the patient, let's focus on the preoperative visual acuity, the macular hole size, and macular hole duration, and look at that more carefully. Preoperative visual acuity, sometimes poor at presentation, even in small holes. However, most of the time, the preoperative visual acuity is affected by the duration of the macular hole and the size of the macular hole. Larger macular holes tend to have worse visual acuity because there is retinal atrophy that occurs at the edge of the macular hole. And the duration affects this retinal atrophy and visual acuity, so longer duration of macular hole presence is associated with larger macular holes and poor visual acuity outcomes. And there's evidence in the literature that longer duration of macular hole presence leads to less good vision outcomes, and the first such study was published by Brooks in 2000, where he demonstrated that the portion of patients that achieved 20/40 or better visual acuity outcomes was much greater in macular holes that were less than 6 months old compared to those that were older. More recently, Murphy and colleagues did a very large study of 940 patients in an individual participant data pooling study, which is something similar to a meta-analysis, but much more detailed. And they also showed that the time to macular hole surgery affected the postoperative visual acuity significantly. And it also affected linearly the closure rate. So the older the hole is, the less likely it was to close. How can artificial intelligence help us? It turns out that artificial intelligence was not helpful as an additional factor to clinical factors in considering the predictability of macular hole closure and vision outcomes. And how do these factors relate if we go back to duration, macular hole size, and visual acuity? We can see that time leads to more retinal atrophy and photoreceptor loss, which leads to poor visual acuity. So that sounds very similar. Photoreceptor loss, poor visual acuity with time sounds like the prognosis of a retinal detachment. And indeed, a macular hole is a foveal photoreceptor detachment, a foveal retinal detachment, and should be considered as such. Good vision outcomes are perhaps because it's a very shallow detachment. So macular hole represent a foveal retinal detachment, and the interval to surgery affects the outcomes. And perhaps they should be treated with similar urgency to macular off-retinal detachments. I'll leave you with that question. So going back to our goals of surgery, visual acuity is important, so operate early to get good visual acuity outcomes, and closure is important, so operate often if necessary to close the macular hole. And I'll leave you with this last thought: open macular holes are lost opportunities. Thank you.